Good morning. I now convene this morning's hearing entitled "Where Have All the Patients Gone?" Examining the Psychiatric Bed Shortage. Dr. Evans, you're recognized for 5 minutes.
Thank you. Mr. Chairman, Dr. Murphy, Ranking Member Representative DeGette, and members of the committee, thank you for inviting me to participate in this hearing. I'm Dr. Arthur C. Evans, Jr., Commissioner of the Philadelphia Department of Behavioral Health and Intellectual Disability Services, and I also have a faculty appointment at the University of Pennsylvania School of Medicine. I appear here today on behalf of the American Psychological Association, which is the largest scientific and professional organization representing psychology. As a commissioner of a Department of Behavioral Health, my job is to ensure that the resources are deployed to address the needs of 1.5 million people in the city of Philadelphia. So today what I wanted to do is to talk as an administrator, as someone who's trained as both a scientist and a practitioner, and also a family member myself. And I want to start by saying I think all of the issues that we've heard today are solvable problems. I absolutely believe that. I think we have evidence both in Philadelphia and around the country that all of the issues that we've heard today are solvable, I think, with political will, with resources, and with leadership. I think, and I really appreciate the family members who have testified today, and especially Mr. Rahim, who gave his personal story, because I think that we have to hear that people can and do recover. And I want to start my comments by just giving a few examples of things that I think that we can do to improve the nation's mental health systems. First of all, people can and do recover. And we know from the research, we know from clinical practice, that given the right resources, given the right types of services, people can do really well who have even the most serious forms of mental illness. Unfortunately, our systems are set up in a way that they don't acknowledge that. We have systems that are geared towards maintaining people, addressing people when they're in crisis. And you heard some of the stories of people who have family members who have a very difficult time getting help. And the reason that is because of the way we finance our mental health system. It is diagnostically driven. People have to either have a diagnosis or to be in crisis. So one of the first issues I think we have to take on is how are we financing our services, and are we doing things that, and are we financing our service system in such a way that we have the resources to do outreach and to do early intervention. Secondly, I think that any discussion around psychiatric bed capacity has to deal with the efficiency of the current system. There are a number of things that we can do to improve the current efficiency, and I'll give you a couple of examples from Philadelphia. We have in Philadelphia a unit that has people who historically would have been in the state hospital, very long lengths of stay, numbering sometimes in the months. We've employed evidence-based practices, both on the unit and in deploying ACT teams or assertive community treatment teams who've also been trained up in evidence-based practices. And we're starting to see a reduction in lengths of stay. I use that as an example because when we talk about increasing bed capacity and not addressing the inefficiencies in the current system, it's not a good use of our resource, and I think we have to take on those issues. Similarly, we use a pay-for-performance system because we believe as a payer that it's really important to have accountability around the services that are provided. We have saved over $4 million over a 2-year period simply by working with our inpatient treatment providers, focusing on things like continuity of care, making sure that when people are admitted that if they have a case manager that those people are coming on to the units, working with people so that there's a smooth transition. Those kinds of efficiencies can go a long way in increasing capacity. I also believe that we have to have a public health strategy. We cannot have simply a treatment strategy around this. When people have difficulty getting into services, sometimes that is because people don't know how to navigate the system, but often it is because there is stigma associated with mental illness that prevents people from reaching out for help. And so part of our strategies have to be to reduce stigma and make it more likely for people to reach out for help. That's one of the reasons that we support things like mental health first aid that help people to understand how to intervene. Fourthly, I think that we have to think about cross-systems financing. Many of the issues, if you talk to mental health commissioners around the country and you ask them what are the top 3 issues, I would almost guarantee you that every single one of them would have housing as one of their top issues related to the administration of their system. And so as we're talking about this, we have to think not only about services within the mental health system, but we have to think about other services that people need to be successful. So with that, I will stop, and hopefully we will have questions that we can talk more about those.
Thank you, Dr. Evans. As we